Free audio post-production by alphonic.com.
I'd like to begin this podcast by acknowledging the Turrbal and the Yugara people, who are the traditional custodians of the land on which we meet today to record this podcast. I also would like to pay my respects to their elders past, present, and emerging. Hello, Academy Associates. Thanks for choosing to listen to the BarbellJack Academy podcast, where our aim is to bring clinical research to real-life clinical practice. For further learning opportunities, why not access our educational webinars? To access, click on the link in the show notes. To keep up to date, join our Academy mailing list where you'll receive exclusive content, discounts on webinars, and more. Link to join us is also in the show notes.
All right, welcome back, listeners. Today we're going to be recording a podcast on rotator cuff-related shoulder pain, or RCRP, it's known as. So today I'm joined by Caitlin from Milton Physio. She's been in a few podcasts before, but I'll hand over to you, Caitlin. Can you just let the audience know, or for those new listeners, a little bit about what yourself and currently deep in study at the moment? So fill us in.
Thanks, Gage. So I'm a titled musculoskeletal and sports and exercise physiotherapist working out of Milton Physio in Milton, Queensland. And I'm currently on the specialisation training program, which is a training program to be recognised as an expert level physiotherapist in Australia. So in clinic, I deal with predominantly musculoskeletal and sports related injuries across the lifespan. So anywhere from neck, shoulders, wrists, hips, spine, ankles, you name it, we pretty much have a look at it, which is good from a rehab perspective.
A little shout out to Caitlin. She's actually here on her holidays at the moment. So she said this is a fun part of her holidays. So thanks for coming in.
One fun part of it.
Yeah.
One fun part.
Awesome. We'll get into it. So a big reason of the topic today, coming from an EP's perspective, wanted to chat about sort of common presentations of rotator cuff related pain, when we might see it, how to assess it, what's the things to ask, what's the things to look for, things to avoid. So a bit of sort of an assessment and then some early phase prescription. So I guess starting off, there's a lot in our field that we learn of in saying that we don't diagnose anything. But I know in the last sort of 5 years or so, we've shifted towards labeling things that rotator cuff related shoulder pain, as opposed to, your supraspinatus tendinopathy and things like that. What are some common assessments that you do for the rotator cuff, and how would you identify someone with rotator cuff related shoulder pain?
Great question. And really important that we're having this conversation around rotator cuff related shoulder pain, because rotator cuff related shoulder pain is now an umbrella term for, as you mentioned, a number of different conditions associated with the shoulder. So importantly, as part of your assessment, is we want to identify, is this actually a pain associated with shoulder movement mechanics with it? So from a EP screening perspective, you want to screen, is the pain isolated into the shoulder? Are there movements of the shoulder that reproduce the pain? Making sure that it's not something that's potentially coming from the neck or the upper back. So if someone's reporting that neck movements are reproducing their shoulder pain, or spinal movements are reproducing their shoulder pain, that's probably one to refer on with it, because it's unlikely to be directly isolated to the shoulder itself. Also, it's with rotator cuff related shoulder pain, you won't have someone reporting paresthesia, so they shouldn't be reporting pins and needles, numbness, altered sensation. And they're ones, again, where you go, okay, this presentation might not be something that's amenable to starting directly under EP management. And if they haven't been screened by physio, referring on from that aspect of it. But then if you're happy that, okay, they're presenting with primarily shoulder-related pain, it's about understanding the mechanics of the movement. So with their presentation, is their shoulder stiff? So when they're moving, are they saying, oh, it's stiff, I can't move it any further, potentially osteoarthritic related? Or is it something where they're saying that they've got a painful arc, so they're saying they're getting pain through a certain pattern of movement, normally through shoulder abduction? They're ones that you might be thinking, okay, this could be a little bit more rotator cuff related that we can have a little bit of influence on. Excellent. From that aspect.
So I guess from my experience and my sort of teachings, which is probably a little bit outdated now, but I did do relatively recently, or the last few years, Adam Meakin's shoulder course, which was quite interesting. In my experience, rotator cuff related pain, it's generally going to probably produce in that painful arc. So when a client is moving with an abducted or a flexed arm, so something sort of around that shoulder height or above that shoulder height, commonly the discomfort is going to sort of be around that sort of point of the shoulder, with some referral generally down the delt, is a common thing that I sort of see in my experience with people with these confirmed pathologies. What are some other things that they will say? So let's say we've cut all our red flags. We're not thinking neck. We're not thinking anything else. What are some common presentations that you see?
So common presentations I'll see is that clients will report that they get pain during activity and rest helps with it. So if they're either avoiding movement patterns or it's not as high a load, they won't report their presentation with it. I've often found that with rotator cuff related shoulder pain, it is common to have it around the deltoid area, but you can also have it anteriorly along the biceps as well, because the bicep is trying to accommodate for the change in rotator cuff loading in some presentations. And sometimes it can be posteriorly as well, because the posterior capsule is not allowing that freedom of movement or trying to then compensate for that lack of rotator cuff control as well with it. Patients will also say that it feels really nice if they stretch it. They'll often say, oh yeah, stretching feels good, or if they have a massage to the area, it feels like they have reduced pain presentations as well. So they're often the key things I'm listening for.
Yeah, excellent. I guess moving on, we're all sort of aware of special tests and when to use them. The PD that I did, it sort of said that special tests, not the greatest, but when used together can give you a better understanding of where you can guide your treatment. So from my understanding, using sort of like your empty can, positive, a painful arc, and I think it's your Hawkins-Kennedy potentially, is usually a pretty good sensitivity for rotator cuff related shoulder pain. What physical assessments would you be doing with a client with this presentation?
So from my perspective as a physiotherapist, I'm trying to prove what it's not with it. So around the shoulder, I want to have an understanding, is there a labral contributing factor to this as well with it? But again, in that EP space, you want to be having an understanding of, well, what's pain provocating with it. So yes, if they're reporting shoulder abduction is provocating and it's more provocating painful when they've got their forearm in a pronated position, then yes, that's going to inform it. If they're reporting when they go to reach across to the other shoulder, that's potentially more pain provocating, then yes, that's going to continue to inform that clinical picture that you might go, okay, this could be more rotator cuff related. But it's also about understanding, because you guys do a really good strength assessment, well, what's actually happening from a shoulder movement perspective. So if you're having a look at internal rotation, external rotation under load, what's the differences in strength relating to that as well? And that will continue to inform your clinical picture with regards to, is this something rotator cuff related that we can have an influence on in EP space?
Excellent. And when you are going through your assessments, obviously we should all know what makes up the rotator cuff. Are you looking at specifically what part of the rotator cuff is affected, or are you sort of treating it a little bit more holistically? And a bit of a two-parter. I guess that umbrella term, are you also wary of tearing, and how would like a rotator cuff tear versus like a tendon issue? And how would that present differently as well?
So from the first part of it, our tests are not specific enough with regards to what muscle is involved around the rotator cuff, because they've got a combined loading pattern with it. So when we're doing our clinical tests, we're more having a look at what's happening with shoulder external rotation, what's happening with an internal rotation perspective, what's happening with a bicep loading. So that one is probably giving you a little bit more specific information from there, but it's more about that overall movement pattern with the shoulder through there. Then with regards to the second question was specifically about
tears versus sort of maybe more tendinopathy related pain.
You in clinic are not going to know if an individual has a tear or not unless they've had imaging done with regards to it. And a lot of people have major rotator cuff pathology and are fully functional with it because often it's degenerative. The ones you need to watch out for is if you have someone that you've been managing for rotator cuff related pain and they suddenly come in and they've lost function, they're unable to move their arm, they're ones you need to refer on soon because they're ones that have likely had a change to the pathology that may be underlying their pain. So in clinic for me, if someone has reported tears or reported tendinopathic changes, it's more about the function of the individual. So, okay, I've got a patient at the moment who is 66. She's had an 18-month history of shoulder pain, had imaging 12 months ago that confirmed a supraspinatus full tendon tear. She's got full range of movement. She's never lost range of movement with it. Her issue is long lever positions are pain provocating, which is affecting her job. So that's someone that I go, okay, she is functional with her tear. What she's lacking is the capacity for long lever movement. So we need to rehabilitate that from a functional perspective through there.
Excellent. No, that'll make sense. And I think from your end, it comes very much from that functional perspective and how things are moving.
Hello again. Thanks for taking the time to listen to our podcast. Another shout out to a sponsor that we have, the BarbellJack, where you can master your lifts to save time, energy, and lift like a pro. The BarbellJack isn't just any gym gadget though. It's your new best mate, designed to ensure a safe posture when changing weight plates. This is a must-have in your clinic. Embrace the power of professional lifting techniques and hit your personal records with ease. Use the code BODYTRACK to receive 10% off your order. Now back to the podcast.
My next question was going to be along the lines of, in terms of rest periods and deloading the shoulder, what's a good rule around, let's say it's just stirred up, is sort of total rest or I guess what we say, unavoidable activities for people. Is there a good time frame for that to suggest for clients? And do you give much advice around sort of positions to avoid? Obviously, we don't reproduce the painful positions, but in terms of sort of setting the arm or supporting the arm in certain ways.
It depends on how the individual is presenting from an irritability perspective. So if someone has low irritability, so it takes a fair bit to wind the shoulder up and then recovers quite quickly from a pain perspective, they're ones that you could be comfortable doing a little bit into a pain provocating position as long as it settles down quickly as part of their presentation. But if you've got someone that's really irritable, they're highly sensitized from a pain perspective, they're ones where you really want to dampen down that pain response. And it's going to take a little bit with them to identify what is their reporting is their primary aggravators, or they might not know that when they do a load of washing and then they do the ironing and then they cook dinner, that's why they're struggling to sleep overnight, even though they're saying they're doing nothing. You've got to actually have a look at the individual and what makes up their lifestyle as well from there. So I don't essentially have a hard and fast rule that I follow with everyone that comes in. I take it all into consideration. And if I've got someone that's saying, yeah, every time I go to the gym and I do this activity, it's aggravating, well, we limit that activity. If someone says, when I iron for more than an hour, that's what really winds me up. Okay, let's iron for 30 minutes. Or is there someone else that can do your ironing this week to see if we can dampen that down? So you've kind of got to make it quite individualized with it. But when someone's really, really sensitized, you might be looking, let's give it a whole week to settle down from there.
Yep. Excellent. That makes sense. And I like the term of that irritability, or sort of assessing irritability. And I think it's like your example of washing, ironing, things like that. I think it's a very underutilized portion of our role where we're asking those questions, potentially in that subjective questioning where it's like, oh, have you done anything that you feel like might have aggravated? It's like, well, no, I just did my usual day. And it's like, okay, well, take that next question and be like, well, what is your usual day? Did you do some ironing? Have you been working on the computer for a certain amount of time? So, educating those clients on connecting those dots is really important as well. Excellent. Early intervention. In terms of strengthening, I know what your answer is going to be in terms of find the thing that they can't do, build towards doing it, or looking at sort of, are there any deficits in strength? And it's okay, why is this pain there? When we go back to the old school internal, external rotations of the shoulder, banded, things like that, is there a place for that in rehab?
Absolutely there is.
Yep.
So it comes down to, and again, from a physio perspective, the way that I look at it is I'm not just looking at does someone have a full shoulder range and movement. I'm also looking at, well, how can I get them to alter that? So a lot of people do have pain with shoulder external rotation at 0 degrees. What can I change that then changes their pain response? So if it's something associated with axioscapular control, if I change their axioscapular position, then can they perform shoulder external rotation without pain? Yes. Okay. Let's add resistance. Oh no, I can't do it with resistance. There's the perfect example of someone that would be appropriate for your shoulder external rotation at 0 degrees. You're thinking about what you're doing it for. It might not be from a targeted strengthening perspective. It might be more from a control perspective and then progressing that through range. So that's kind of where we need to consider the role of a shoulder external rotation. So from the first aspect of the question, is rehab always strengthening? No. Rehab isn't always strengthening to start with rotator cuff related shoulder pain. If they've had a long history of it, it might actually be addressing their awareness of where their shoulder is in space and time. So do they need more of that proprioceptive exercise focus? Or do they need more of a motor control where they're actually learning, okay, can I maintain this position under a little bit of load? And then you may address the pure strength changes from that. And then there's the opposite side where someone may have good proprioceptive awareness. They've got good motor control. So then, yes, you then target direct strengthening, and that will be addressed in, well, what deficits have I identified? And then when it comes to the strengthening, it comes back to, well, how are they doing that movement pattern? If they're doing a shoulder external rotation, but they've dropped the head of the humerus forwards, you might need to give them some different cues to start that external strength, rotation strength.
Yeah, excellent. And that makes a lot of sense. And I think a lot of the time, probably in our profession, people can be quick to jump to, okay, let's do these exercises because it's rotator cuff related pain. But I think it's important to assess movement quality. I think I'm not a huge believer of, great scap rhythm and things along those lines. But a big one would be assessing, okay, well, how does your non-painful side move versus your painful side, having some sort of comparison, but actually looking at, okay, maybe the shoulder's quite sore, but we can tolerate things below 90 degrees. What does a little bit of an incline push-up look like? How's the scap moving through that? What does a seated row look like? How's the scap moving through that? So I think there probably needs to be a little bit more room to modify exercises and not just cull them because they're sore from the first go. I think a very common thing that I see going back to like that scap positioning is probably people not actually elevating their scap enough. I think we see a lot of sort of scap sitting forward, like you said, maybe a little bit of humeral head sort of translation. So actually cueing and building a little bit of strength around the upper traps and the levator scap and being able to pull the shoulder up a little bit more.
That probably leads into a really good thing. If everyone could stop giving the cue, pull your shoulders back and down, that would be great.
Yeah.
Because that's a discussion for another point, but that's our shoulder blade needs to move. So exactly with what you're saying with regards to an elevation, we need to be teaching people to open their shoulders rather than forcing it into a position where they're thinking they're stabilizing, but we need to allow the shoulder and the upper quadrant essentially to move.
Yeah. I think I think it's changing a lot in our landscape, but I see, like when I went through uni, it was like shoulders back and down. It was just like ingrained in your mind. But I think for us, there's a big place to promote letting your shoulder blade move freely, but also I like the lift and the lock, is what I generally go for like a pull-based movement. But then in push-based movements, we probably want a bit more of that upward rotation. So not actually forcing the shoulder blade to stay back. But yeah, that's a bit of a triggering one there, whole shoulders back and down. Awesome. So in terms of rehab timelines for rotator cuff related pain, it's got too many two-part questions, but what's a general guideline in terms of weeks, months, time period? And when would you look for scans? Would that be when your rehab's not going as planned? And what time frame for that?
So if you're working in isolation, so someone's come to you, you're going to trial a period of exercise under a GP management plan. If you are working on, promoting axioscapular control, adding a little bit of loading, you should see comfortable change in 6 to 12 weeks from your general loading parameters. If you've got someone that's in a lot of pain with it and you're really struggling to get that loading happening appropriately, that's someone where give it 2 to 3 sessions. And if it's not improving, you need to refer on to a physio for further assessment to identify what's going on from that aspect. Because if there's a lot of pain, sensitivity, loss of motor control associated with that, you're going to expect a longer recovery time frame. From a scans perspective, it depends on a lot of different factors. So as I mentioned earlier, if you've got someone that has been going through rehab and then has sudden loss of function, there's someone that would be referring back to have imaging done because there's been a change in their clinical presentation. Just because someone's not improving doesn't always mean we need to image. It means that we kind of need to take a step back and go, what are we missing? So again, from an EP perspective, if you've been managing someone and they're really not hitting the timeframes you would expect, or they're not getting the strength progressions, refer to a physio and get them to just sort of take that bigger picture step back going, what else is potentially contributing to this presentation that might need to be addressed in conjunction with what's being done to then hit those next milestones. So general rule of thumb, would expect changes over 6 to 12 weeks if there's no other pathology contributing to it.
Yeah, excellent. No, that all makes a lot of sense. And I think a big thing as well as in our space, not being afraid to trial different exercises and positions and things. I find that probably most commonly we see issues in supraspinatus, maybe infraspinatus as well. Sometimes subscap, but less. So generally with that, a lot of people are provocated by push-based movements because a lot more of the posterior cuff is turned on in a push-based movement. So, utilizing your pain-free pulls and things like that and experimenting with a lighter weight and then modifying, like what you said, okay, this person can't externally rotate, but can they externally rotate in this position or that position? And modifying is really important. I think sometimes gets missed a lot because we say okay, rotate this band. If you can't rotate this band, then oh no, this could be something worse.
I think another aspect that comes into that is don't be afraid to keep someone at the same level. So I see a lot of people come in and they want to go harder and faster. But with some of these presentations, you don't want to change too much at once. So it might be if you started someone with a program, they might not progress week 2. They might progress week 4 or week 6, depending on what their quality of movement and control of movement is like. So that's always something to keep in the back of your mind as well, is that if you see someone, you progress them and they have a flare, keep them at that same level for a little while. It's going to help build confidence. It's going to help improve movement patterning, and it's going to help reduce that pain response as well.
Excellent. That's great. I don't think I had any more questions related to the rotator cuff specific pain. I think it's a bit of a rabbit hole. I think there's all, like we said, say umbrella term, there's a lot of different sort of subsets. But if you could give sort of one main piece of advice for someone treating rotator cuff specific pain, what would you deem the most important thing?
The most important thing, I think, when it comes to rotator cuff related shoulder pain is you need to look at the whole of the person to understand what other contributing factors may be coming from lifestyle. But you also need to look at the whole upper quadrant is probably the biggest thing. So don't just focus on the shoulder. Look at what's happening from a scapular perspective. Look at what's happening from a thoracic perspective. But then also look at what's happening from an elbow and a wrist perspective as well.
Yep. Excellent. Thank you.
No worries.
Thanks for listening. We hope you enjoyed this podcast. So remember to share, like, or follow to keep updated with all our podcasts and educational resources.
Free audio post-production by alphonic.com.